Welcome to all of you this pleasant Sunday. Sunday generally all of us would prefer to spend with the family after a hectic week, and we are quite happy and impressed that many of you kept your personal agenda aside and come forward for the common cause. And that shows that there are a good number of people who are willing to come forward for a good cause, and we are really happy to have all of you here. Before we start and proceedings, I have a responsibility to introduce Mr. Rajashekaran. Mr. Rajashekaran has been associated with the Dr. VSN Geriatric Foundation since 2016. Very interesting personality, Mr. Rajashekaran. He is heading the entire Dr. VSN Geriatric Foundation initiative, because doctor has been busy. He has been taking care of a scientific content, propagating a scientific content, getting people to support his program, but all are executed in the back end by Mr. Rajashekaran. So Mr. Rajashekaran is basically a management graduate. He's a serial entrepreneur. Especially he was involved in medical conferences, managing medical conferences. That is how he got connected with Dr. V.S. Natarajan. They shared the same thought, same noble thought of India is a country which is going to have a good number of population, geriatric population. Then they shared their wisdom. They understood they both are sharing the same interest. Then they started working together since 2016. And now Mr. Rajashekaran is the co-founder and managing trustee for Dr. V.S. Natarajan Geriatric Foundation. The ultimate objective of Dr. V.S. Natarajan Geriatric Foundation is that to enhance the quality of life to elderly. The number of life expectancy, especially in India, has gone up significantly. It has gone up, and all the more in the southern part of the country because of the better medical infrastructure. Recently, there was an article also published in Times of India. Kerala leads the maximum number of geriatric population in the country, followed by Tamil Nadu. Tamil Nadu is the second state which is having maximum number of geriatric population, and it will go up significantly. It will go up in the future to come. And the purpose of this academy is to promote geriatric health, to promote home health care. Doctors' very favorite topic, home health care, because it is around. It is like a round we are coming back, because in those days, maybe in early 1940s, 1950s, the doctor visiting to the home of a patient was normal, very normal phenomena. Then we have progressed to the level of the number of doctors were lesser compared to the population. So the doctors started consulting in their own places. Now we predict a future. The geriatric house call will be the huge opportunity. There will be significant number of doctors. Now itself there are a good number of doctors wanted to do it. And there is doctor will explain in this thing, the in-house call program, even Dr. Harishikar will explain, the geriatric population feel extremely comfortable. They feel a lot of fear when they visit to the hospitals, especially bigger hospitals, corporate hospitals, when a lot of patients are there in and around, and the way the hospitals are constructed, the way people behave in them, it gives a little different feeling, insecure feeling. When the doctor visits to the patient itself, to the home, which is a very familiar place, the patient is also very comfortable, they are able to do it. So this is how the future plan, Dr. Harishikar is the right person to explain the future of home call, geriatric home call. We also feel as a part of supporting this industry, we also realized this geriatric house call is going to be a big, going to see a big boom in future. And also Dr. V.S. Geriatric Foundation supports academics and skill development related to geriatric health. This is a holistic objective, and we have been started associating with Dr. V.S. Natarajan Geriatric Foundation and Rajashekaran for the last couple of years. We started initially started participating in Pudumai Innum Poogatru and the magazine first pannom. But we are really impressed with the kind of initiative they are taking it, and we thought it is our moral responsibility to support such initiative. It may not be a business or legal responsibility. It is our moral responsibility, because we are all going older, and we realize the doctor noble objective, how it is supporting. We have seen the kind of the impact that the Pudumai Innum Poogatru is doing in many of the individuals' life. நிறைய feedback கொடுக்குறாங்க, இந்த மாதிரி ரொம்ப சப்போர்ட்டிவாக இருக்கு, especially elderly living alone. And we started seeing, I was also making comment to my colleagues, this generation which we given birth after 1970 is seriously responsible for breaking the social infrastructure of கூட்டு குடும்பம் அப்படிங்கிறத உடைச்சிட்டோம். படிச்சு வாழ்க்கையில் முன்னுக்கு வரணும், வேலைக்காக எல்லாரும் விட்டு போயிடுச்சு. நிறைய எல்டர்லிஸ் இருக்காங்க, வீட்டில் தனியாக இருக்காங்க. அவங்களுக்கு the biggest companion is book. All the more the book like முதுமை பூங்காற்று which comes is a very big boost. It gives enormous confidence to them. Many of them gives a feedback that sir the magazine வந்து படிச்சதுக்கு அப்புறம் ஒரு next 2-3 days their approach towards life is completely different. They don't feel that elderly is a curse. They feel elderly is a privilege to have it. So to that extent the book has influenced significantly for a good number of population. It has definitely touched the lives of many people, and we have a lot of living example in our own office and office colleagues' parents. There is always a request, we go to the doctor, sir, please give more number of copies. There is a huge demand to that. Good number of work. All this has been done by Mr. Rajshekhar. So I request Mr. Rajshekhar, please come forward and brief about, he is the right person to brief about what are all the kind of initiatives they do, what kind of implication it is going to have, and the kind of time and energy is spent to it. And they look for sponsors, they continuously perceive the sponsors, they ensure that the magazine never got delayed. Mr. Rajshekhar is very particular ensuring the content is coming on time, printing quality, and he will ensure that the advertising material comes on time. And if the advertisers gives advertising material, if there is any mistakes after proofreading, he himself does a proofreading. He does it, sir, please correct it. All those things he does it. It is beyond his limit of working area, but still he does it because of involvement. I request Mr. Rajshekhar to please come and take care of the proceedings. Thank you.
Thank you, Mr. Rajkumar. Thank you for the wonderful introduction. Our last lesson like he mentioned as if I am doing a lot of hard work, but really I am doing backseat driving. Dr. VSN does all the work, and now forum like when we go on behalf of Dr. VSN to meet somebody, they just not just open the doors, they even roll out the red carpet. So all thanks to the tremendous work done by Dr. V.S. NATARAJAN single-handedly for the past 4 decades in the domain. So it is very easy for us to, even Mr. Rajkumar put over 2 years ago when he came to meet us, like he came through the front door, as we say, no recommendations, anything. அப்போ நான் அவர்கிட்ட சொன்னேன், நீங்கள் டாக்டர் விஎஸ்என்கிட்ட போய் நீங்கள் நேரடியாக பேசலாம் அப்படின்னு. But from there the journey has come so far. MMC Pharmaceuticals and Dr. V.S. NATARAJAN are very thick associates now. This is our second academic program supported by MMC Pharmaceuticals. Our founder and chairman Dr. V.S. NATARAJAN எப்போ ஏதாவது பண்ணணும் அப்படின்னே we'll ask MMC அப்படின்னு சொல்லுவோம். MMCல கேட்டால் they also have supported us. So thank you for all the things that you are doing, sir. And a warm welcome to all the doctors and healthcare professionals who have found time on a lazy Sunday, and we know how busy you are, hectic schedules run pandringa, particularly in the pandemic time. Despite all that, on a Sunday afternoon, you have heeded to our requests and you have come here. So I am so happy that I have met each one of you personally, and you have given the regards and you have accepted our invitation and you have come here. Thank you and welcome you all. Now, the foundation is basically the vision of Dr. V.S. NATARAJAN, and today happens to be Teachers' Day, and Professor wishes to Professor Dr. V.S. NATARAJAN and all the teaching faculty here, happy Teachers' Day, sir. Like doctor distant students, I mean our direct students இருக்க மாட்டாங்க, அவங்க நாங்க மீட் பண்ணும்போது அவ்வளோ ரிகார்ட்ஸோட சொல்லுவாங்க, like we used to have such stalwarts as teachers அப்படின்னு. So it's an apt that நாங்க பிளான் பண்ணல, actually the Teachers' Day நாங்க பிளான் பண்ணல, but it so happens. Like to tell about the foundation's activities, basically foundation வந்து ஒரே ஒரு மிஷன் தாங்க, which is happy elderhood. So what we want to work on is the old age life. Like எந்த ஒரு elderly person நாங்க மீட் பண்ணும்போது அவங்க என்ன எக்ஸ்பிரஸ் பண்றாங்கன்னா, old age is, it is not a happy time to be அப்படின்ற மாதிரி சொல்லுவாங்க, இது ஒரு புயல் அப்படின்ற மாதிரி சொல்லுவாங்க. அதனால தான் specifically Dr. VSN insisted that the journal that we bring will be called as முதுமை என்னும் பூங்காற்று. ஸோ அந்த முதுமை என்னும் பூங்காற்றுன்ற மேகசினோட டைட்டில் சொல்லும் போதே எல்லாருமே கொஞ்சம் அஸ்டானிஷ் ஆவாங்க. எல்டர்லி பர்டிகுலர் என்ன சொல்லுவாங்கன்னா, அது பூங்காற்று கிடையாது, இது புயல் அப்படின்னுவாங்க. ஸோ நாங்கள் என்ன அவங்களுக்கு சொல்லுவோம்னா, அதை பூங்காற்று ஆக்கிறதுக்கான வேலையை தான் நாங்கள் பண்ணிட்டு இருக்கோம். ஸோ தட் sums up what we do in the foundation. So ஒரு quality, our goal is to bring quality at the old age of every individual. And as a foundation, right at the start, நாங்கள் என்ன டிசிஷன் எடுத்தோம்னா டாக்டர் என்ன சொன்னார்னா the care has to go to each and every elder. So that is why we didn't start a unit. இப்போ நிறைய பேர் என்ன சொல்லுவாங்கன்னா நீங்கள் ஒரு ஹாஸ்பிட்டல் ஒரு 200 bedded hospital or a facility அந்த மாதிரி ஆரம்பிச்சு நீங்கள் you can care for that many number of elders. But டாக்டர் என்ன சொன்னார்னா each and every elder to begin with in the Chennai district and then rest of Tamil Nadu, if possible rest of India, we have to provide some support in some manner. So இதை achieve பண்றதுக்கு we have embarked on a mission which has got 3 verticals. So the first vertical வந்து media, like the communication is key. நம்ம என்ன பண்ண நினைக்கிறோம், what are the issues, what is the impact it has got on an individual elder and the society on the whole. We have to communicate. அதுக்கு we have brought out the brainchild of our founder and chairman Dr. V.S. NATARAJAN, which is முதுமை என்னும் பூங்காற்று தமிழ் மாத இதழ். உங்க எல்லாத்துக்குமே நான் மீட் பண்ணும்போது அதோட காப்பீஸ் கொடுத்துருப்பேன். Quite a few of you must be subscribing to it. So முதுமை என்னும் பூங்காற்றுவோட editor and publisher is Dr. V.S. NATARAJAN. He is hands on in it. அது on time வருது அப்படின்னா அந்த பிரிண்டர் என்ன சொல்லுவாருன்னா எங்களோட மொத்த பிரிண்டிங் போர்ட்ஃபோலியோலே உங்களோட கண்டென்ட் தான் ஃபர்ஸ்ட் வரும், அதுவும் ப்ராப்ளம் இல்லாமல் வரும் அப்படின்னு சொல்லுவாரு. So that is the kind of concentration and the effort Dr. VSN is giving to the magazine, and the magazine is well received. தமிழ்நாட்டிலோட எல்லா டிஸ்ட்ரிக்ட்ஸ் மட்டும் போல it is even going to out of தமிழ்நாடு. லைக் தமிழர்கள் இருக்கக்கூடிய கொல்கத்தாவா இருக்கட்டும், நாக்பூர், குஜராத், ஹைதராபாத், பாம்பே. அண்ட் என்ன மாதிரி இருக்கும்னா ஒரு அந்த புக்கை வந்து எவ்வளோ அவங்களுக்கு பிடிக்கும்னு சொல்றதுக்கு இப்போ இது ஆனுவல் சப்ஸ்கிரிப்ஷன், சப்ஸ்கிரிப்ஷன் மாடல். அப்பப்போ சப்ஸ்கிரைபர்ஸ் கூப்பிட்டு இது எப்போ சப்ஸ்கிரிப்ஷன் முடியும்னு தெரியல, நான் இப்போவே பணம் கட்டிடுறேன், சப்ஸ்கிரிப்ஷன் டிலே ஆயிடுச்சுன்னு சொல்லி அனுப்புறதை நிறுத்தாதீங்க அப்படின்னு சொல்லிட்டு இருப்பாங்க. ஸோ வி ஆர் ஓவர் சப்ஸ்கிரைப். ஸோ அந்த மேகசீனை பொறுத்த வரைக்கும் கான்டென்ட்டாக இருக்கட்டும், அந்த சப்ஸ்கிரைபர்ஸோட குட்வில்லாக இருக்கட்டும், வி ஆர் லைக் overwhelmed. And the magazine is growing, day to day it is growing. And very recently for புது எஃபர்ட்டாக we have started the online activities. As you may know, and the yoga at home for elders. ஏன்னா இப்போ இந்த பேண்டமிக்ல வந்து the movement has got restricted, so we have started yoga at home for elders. அதோட சேர்ந்து அந்த மேகசினோட வாசகர் வட்டம், the readers circle ஆரம்பிச்சிருக்கோம், just to have a two-way communication with our readers and the elders. So the first vertical of the foundation is media, which consists of the Tamil monthly magazine முதுமை என்னும் பூங்காற்று, அதோட ஆன்லைன் mudhuvainnumpoonkatru.com and the YouTube channel Poongatru YouTube channel. So this covers all the communication. So we will be interacting with elders. We would like to be the authority. For the pandemic time la pathina everybody was talking about what to do, enna pandrathu, elders enna nalla pannanonu. So we found that there is a lot of discrepancy in what one person, one group says and other group says. So elder oda communication, elder oda information la we would like to be the lighthouse organization. So that is the goal with the media. Second vertical is what we are all here for, which is home healthcare services. Doctor வந்து 10 yearsக்கு முன்னாடியே வந்து home healthcare வந்து launch பண்ணாரு. More than 10 years, 2008 when he was the chairman of Senior Citizens Bureau in the ஆரம்பிச்சாரு. But since it was not his own organization, அதுல இருக்கக்கூடிய various dynamics manage பண்ணியே அவங்க வந்து more than 10,000 patients வரைக்கும் அந்த ப்ரோக்ராம்ல பார்த்தாங்க. But it had its own limitations. So அப்பதான் நாங்க என்ன பண்ணோம், ஃபவுண்டேஷன்ல அதை ரீலான்ச் பண்ணோம். And I'm happy to say அந்த ரீலான்ச் பண்ணதும் MMC ஹெல்த்கேர் தான், சவேரா ஹோட்டல்ல வச்சு பண்ணோம். So you've been part of our journey, sir. ரீலான்ச் பண்ணதுக்கு அப்புறம் it's going wonderful. Like I come and met each one of you. நான் ஒரு தடவை உங்களை பார்க்கும்போது everybody has been more than welcoming, more than being part of it. And we are able to give care to a variety of cases at their comfort in a very little turnaround, and it is growing. So second vertical is home health care. And the home health care services support பண்ணணும்னு பார்க்கும்போது one of the major issues that we encounter is shortage of the specialists, the technicians or the skilled people. Doctors இருக்காங்க, physiotherapists இருக்காங்க, பட் பார்த்தீங்கன்னா கவுன்சிலர்ஸ் இருக்கிறது இல்லை, ஒரு ஸ்பீச் பேத்தாலஜிஸ்ட் இல்லாமல் இருக்காங்க, ஸோ அந்த மாதிரி இப்போ பேசிக் சம்படி டு லிசன். இப்போ நிறைய ஒரு 80-year-old 85-year-old நாங்கள் பார்க்கும்போது அவங்க என்ன சொல்கிறாங்கன்னா, எங்ககிட்ட வந்து பேசுறதுக்கே யாருமே இல்லை, அது ஹெல்த் ஒர்க்கர்ஸ். ஸோ இந்த மாதிரியான கேட்டகரி ஆஃப் பீப்புளை கிரியேட் பண்ணுறது தான் இந்த தேர்ட் vertical, which is skill development and academics. So we are embarked on the journey. I'm so happy that you braved the pandemic scenario and you come here. ஏன்னா நாங்கள் பார்க்கும்போது there are a set of people who say that, you know, the pandemicல நாங்கள் past 1 year-ஆ நாங்கள் வெளியிலேயே வரல, we are all at home, இது முடிஞ்சதுக்கு அப்புறம் தான் we will be starting அப்படின்னு. But you all accepted and come. And இன்னொன்று என்ன சொல்லணும்னா, we are also like, we don't want to stop at any kind of an external situation. We want to keep going. So like I was mentioning, the foundation is working in 3 verticals, sir and ma'am. Number 1 is media. Welcome, sir. Number 2 is home healthcare services, and we look up to you all, your continued support, and we want to take care to the homes of each and every elder through the home healthcare services. Number 3 is skill development academics. We want to fill in the gaps wherever there is a lack or there is a shortage of skilled resource. We would want to create. So this is what we are working in the foundation, and we are quite confident. உங்களுடைய ஆதரவு and with your support and active participation, we are quite confident that we will be able to achieve all these goals and realize the mission, which is happy elderhood. And now a special mention to MMC Pharma. எந்த ஒரு ஆக்டிவிட்டினாலும் we go to them, and they have been, you know, supporting us much more than what we asked for, totally bankrolling the activities. நிறைய பேருக்கு தெரிஞ்சிருக்கும், டாக்டர் VSN has been conducting a medical camp outside of various locations like மேல்மருவத்தூர், சேலம், ஈரோடு, இந்த மாதிரி இடங்கள்ல நாங்கள் மெடிக்கல் கேம்ப்ஸ் பண்ணிட்டு இருக்கோம். பட் ஒரு ஸ்பெஷல் லொகேஷன் இருக்கு, க்ளோஸ் டு தென்காசி, குற்றாலம் பக்கத்தில் இளஞ்சி அப்படின்ற ஒரு குக்கிராமத்தில் டாக்டர் வந்து ஒரு பாஸ்ட் 17 years-ஆ ஒரு மெடிக்கல் கேம்ப், மல்டி ஸ்பெஷாலிட்டி ஜீரியாட்ரிக், காம்ப்ரிஹென்சிவ் ஜீரியாட்ரிக் ஹெல்த் கேர் கேம்ப் வந்து நடத்திட்டு இருக்காரு. இந்த வருஷம் it is very special because of the participation of MMC Pharmaceuticals. They are adding a lot of value additions to the medical camp. So this time on the medical camp la padina anemia detection, neuropathy detection, BMW இந்த மாதிரி, I'm sorry, bone density test, இது எல்லாமே அவங்க வந்து ஆட் பண்றாங்க. So I take this opportunity to thank MMC Pharmaceuticals for all the support that you are giving, and I thank all the doctors and the healthcare professionals who have come here in like I have invited, and you have recognized and you have come on a Sunday, and I sincerely hope this journey will be a great journey, and it will be mutually beneficial. It will be beneficial in all ways. I mean, the elders will benefit, you will also benefit, and the foundation also will grow. So look forward to your support, continued support, and I wish you all a wonderful CME session conducted by Dr. Harishankar. A special mention about Dr. Harishankar. அவர் சொல்லணும்னா he is a champion house call doctor. So அவர் வந்து நிறைய எல்டர்ஸுக்கு செல்ல பிள்ளை மாதிரி. And the geriatric house call manual will be giving in a short while. It's curated by Dr. Harishankar. He co-curated it with Dr. V.S. NATARAJAN, and he has been a big supporter of the foundation. எப்போ நம்ம in short notice அவர் வந்து he will make a nice presentation, and his presentation will be an eye opener to whoever is already doing house calls and who would want to increase the practice of house call. By that, I thank you all once again for coming here, and I invite Dr. Harishankar to give his presentation. Sorry, before
Anyhow, good morning to everybody. Very nice to see a good gathering in this Sunday afternoon. This CM is mainly meant for the geriatric house call program. This is a long time back, probably 2008, when I was the chairman of the Senior Citizen Bureau. I used to go for house calls by myself. I am having an ambassador car at that time, no driver. 9 o'clock I finish my practice. At 9 to 10 I go for house call. Even I go up to Adayar and used to come back late in the night, 10 to 10 at that time. City program was going on. I would take my dinner only around 10, 11. It started affecting my health. So it is not possible for one person to do this job. So let us have a committee. I discussed with the EC members of our geriatric series bureau, finally accepted to carry out on myself. I called all my students, my colleagues, my friends to join the house call program, because this is a very noble program. You spend your 5% of time and money for this cause. You won't believe it. This booklet is printed the first photo. 30 doctors are accepted for varicose. They joined with me along with the physiotherapist nurses. That photo you can see in the first page. 2008, about roughly 13 years back, we started the house call program. And we are doing wonderfully excellent service to the elderly people. Harishankar is there. We have seen roughly, I can tell you, more than 10,000 people have seen. More than the number, the quality of service what you give is something enormous. Many precious life have been saved. That is more important. We can treat the patient, but the precious life we cannot bring it back. So many lives have been saved. We give a death certificate. We give not, and also we give that life certificate. But pensioners they need a life certificate. So we are giving so many other things also in addition to the health care. And you are giving a very good support, Harishankar. And whenever I ask for the house call, immediately I will accept it. Then number two, now recently you have seen the paper, Makkali Thedi Maruthuvam. This was what we started 30 years back. It just came to mind, I can raise my collar, that we are the first to start this geriatric house call program. We had a self-posting, what happened, I just tell you the truth, nothing else. So the government has come forward to start the Makkali Thedi Maruthuvam. It is a very good concept. My sincere wish is it should be extended to villages. The village elderly people should be benefited. It should not be constrained to only the city. It should be benefited that way because. And also they have started giving vaccination, the corona vaccination for the elderly people above 8 years. They can go to the house and they can give injection. These sort of things I want to approach the government. Acharya can write a letter to the secretary tomorrow, because when he approached some time back, they are not giving permission to give the pneumonia vaccine at the residences. It should not be given the camp also, it should be given only doctor's clinic. So many elderly people we cannot offer the service because of the government restriction. Now since they are accepted for the corona vaccine for 8 years above in the house, we can also ask the government to give permission to give the pneumonia vaccine at the house itself. So these are I want to finish very short notice. I want to thank Dr. Harishankar, Mr. Rajakumar for giving the support for Emergency Pharmaceuticals. They are giving a lot of support. Whenever you ask for anything, immediately you say first yes only, then only ask what you want. So that type of service I am getting it. I don't take much of the time. Have a nice day. Harishankar is there to give a talk about our school program. Hari.
A very good afternoon to one and all present over here. At the very outset, today's Teachers Day. School எல்லாம் நம்ம டீச்சர்ஸ்க்கு ரொம்ப ஃபேவரட்டாக இருக்கிற ஸ்டூடெண்ட்லாம் அந்த போர்ட்லாம் போய் கழுவோம், சாக்லாம் எடுத்து கொடுப்போம், அவங்களுக்கெல்லாம் கொஞ்சம் மார்க் கூட போடுவாங்க. அந்த காரணத்துக்காக இல்லை, உண்மையாகவே நம்ம முன்னாடி ஒரு லெஜெண்ட் இருக்காரு. ஹி இஸ் த லெஜெண்ட் ஆஃப் தி செஞ்சுரி. ஃபார் தோஸ் ஹூ டோன்ட் நோ, ஆல்மோஸ்ட் எல்லாருக்கும் தெரியும், பட் ஃபார் தோஸ் ஹூ கொஞ்சம் தெரியல அப்படின்னா, ஹி இஸ் த ஃபர்ஸ்ட் பர்சன் in Asia subcontinent to start geriatrics. So let us all stand and give a standing ovation. Happy Teachers Day, sir. Thank you. Please be seated. And Kandipa, today's session will be of not of a standard lecture on so many events happening in house call. We'll just go through what is happening and it is and how we are following our model, and we'll go through it. And you can feel free, you can feel relaxed, nothing to note. You can just listen and enjoy. And these are real-time pictures. You need a lot. What this image says is you should have a good backup of staff nurses. This is very, very important. So without staff nurses, the role of house care or home care will not be sustainable for a long way. Because you cannot be running for checking a sugar, checking a blood pressure. So you need to have a good standard field force. That is very, very important. And all throughout the presentation, and my thanks to Dr. V.S. NATARAJAN Geriatric Foundation for bringing me to this limelight. And I have used a lot of clinical photographs here. So, and this is nothing from internet or something. This is from our own patients. So I request you to avoid photographs. And this is from where we are from. We are from Old Pallavaram. And as you all know, Dr. V.S. NATARAJAN sir has started Geriatric House Call project from the year 2008. And slowly we have joined his project. And this is the first study that I presented, and this was the conclusion. So, Geriatric House Call project will ensure confidence, psychological boost, moral support and security for the elderly patients. And as far as for the patient's part is concerned, you can avoid unnecessary nosocomial infections, anxiety, and financial burden also can be reduced. And we'll see through, this is just an introduction, we'll see how it is happening. And what are our numbers? So almost around 9,000 patients are visited from our center, and almost 25,000 visits are done. And how do we collectively do it as a team? So from the effect of 2011 to 2018, so we have a single physician-led unit, and I have one surgeon along with me as my classmate. And a few of you need to have some like-minded physicians and surgeons along with you to get a cross-counter opinion, because you might be lacking some space somewhere, so you need to have some like-minded physicians, or because every patient should not be taken as an opportunity to conduct some event on them, like unnecessary surgeries or unnecessary hospitalizations. You need a good team of physiotherapists, because mobilization is the final outcome what an elderly loves. இது முடிஞ்ச பிறகு நான் சீக்கிரம் நடந்துடுவேனா, நான் என்னோட இயல்பு வேலைக்கு போவேனா, நான் பாத்ரூம் நானே போயிடுவேனா, சட்டை பட்டன்லாம் நான் போட்டுப்பேனா அப்படின்னு கேட்பாங்க. And we need a good dentist also. Lot of dentistry can happen at home, like expulsion of the tooth, putting a denture. Denture is very, very important, because they may not be able to communicate what they want to say, or they may not be able to chew, or they might be going for a malnourishment. And we have 10 registered nurses. So you can also think we cannot employ a lot of nurses, so you'll be suffering financially. So you can have good quality standard nurses, and few nurses can be taken as internship to help them around, to assist them. So we also have some 40 nursing assistants on training. You need good locomotion system, you need two-wheelers, you need vans, you need, this is on a large scale, but to start on with a small scale, limited amount of locomotion is sufficient. Smartphone is essential, because whenever you are not able to go, suppose you have visited just in the morning, you have prescribed some medicine and he has ended up in some allergy, or you have removed the catheter, and night he is ending up with some, again, an acute retention of urine. So you need some amount of smartphones, because it is almost, it cannot match what we have seen in person, but it will somehow match. And you also need telecallers, because you need to, a well-informed visit is well received. Suddenly going and knocking the door, as they would have called in the morning, but suddenly going and knocking at the door, they might be anxious. So a telecalling system also will be very efficient, and you need a lot of grief counselors. Already sir has said that there is a requirement for somebody to listen to what they say. Many of the time you may not be in a position to listen. You might have your own problems, you might have your financial burden, you might have your patient's overload at the outpatient. So you need somebody who can talk gently and relaxedly. Of course, you can also do the job. It's not that doctor should not talk. Doctor also should talk. Whenever you are not able to do so, in once in a while, so you need some good amount of grief counselors, and you need your own pharmacies, because why? It will save a lot of time. Now, visit, when we are going for a visit, when you write some injections, it will take some time to go and buy, and again they will come back. It might not be the same mg, or it might not be the same preparation. You will lose lot of time, and losing time generally nobody likes, because waiting is a torture. So generally carrying your own pharmacy, you know what you will be using, like paracetamol, chlorpheniramine maleate, deriflin, dexamethasone, whatever you are going to use, you can have your own kit, so that you don't waste lot of time, and ensuring the quality of the products and the expiry date, all can be solved in a single shot, carrying your own pharmacy. Of course, the sales also carries along you as a benefit. So how our model works, first the call is received from the patient. Generally there can be old patients, there can be new patients, and then the visit is triaged first, whether it is essential or it is very emergency, or it can be done as a casual visit. The first visit always should be done by the physician. Because you can invent lot of new things. They might be calling you for a problem, but the original problem will be for somewhere else. The follow-up visits can be done by the staff nurses, and definitely you need to know an auditing. Auditing in the sense, what is the outcome of your visit? And generally we audit as good, moderate, hospital. So all visits need not be treated at home. Sometimes it can be referred to the nearby hospitals, it is always good. Or sometimes it can be a DNR. Do not resuscitate. Do not hesitate to give a DNR status, because many of the children are well aware that life, birth and death is inevitable. So try to take some time. It is not that we can treat all the patients and we can make the patients everybody walk. All they need is a soothing relief. They need some pain relief from the project. And of course, if it is treatable, definitely we'll jump into the mission. We'll go and see how it is happening. So, and this is how we generally triage. So always the first option of hospitalization should be always given as per rule of law. So home visit, home care is all good to talk, but sometimes you will be encountering some people from abroad, people from their doctor relatives within their own family. Why didn't you do this? Why didn't you refer here? Why didn't you tell them? Please first say the first option of hospitalization is always good. And also the second point, you can say we are full-fledgedly, we are prepared for a home care. So home care can be the first option, but it should come from the patient attender's consent, because majority of the time what law says, patient should give the consent, but elderly, when during their sick phase, they will not be in a position to give consent. So majority of the consent are given by their children or their grandchildren or their niece or nephew. So you need to take a consent for home care, but the first option of hospitalization should always be given. And record maintenance is very important, at least some standard record maintenance like date, time, patient's name, and what is your plan for the patient. And if they're willing for home care, if it is a simple management, you need to prescribe some drugs, then it is fine and good. You are planning to do some intensive management like hypoglycemia correction, hyponatremia correction. So the extent of home care, what we are going to discuss, is going to be like from outpatient to intensive care. We can manage even up to intensive care patients at home. If you are fully thrilled and you are enthusiastic, the game is yours. So earlier the hospital model, so initially when there is some, whenever you go for house calls, and the doctor clinic patient varla pola iruppa, adha veedu vida porar appadina sila per nagai adithalum nagipanga. But irundhalum there is nothing new, where a physician goes to 4 hospitals, 5 hospitals for his consultation. Here a physician goes for 4 or 5 homes a day to do his home care. So there is nothing wrong, and there is nothing to be, I felt as that part, my classmates used to, but to break that stigma, I just showed this model. So this is nothing new that what a consultant does, a home care physician does. And like reminding you of old things, and these are all old things, and home care is also like you would have seen in the old Shivaji Ganesan's movie, Gemini Ganesan's movie, the doctor used to come with a bag immediately as soon as the hero or heroine is sick. But today it is now outdated, but still it is now again like old wine in the new bottle. The government also has started recently, our stalwart has started it almost 13 to 15 years back. So we are now on the trend. This is not that we are going somewhere back, or this is something bad or something which will not be remunerable. So this is something good on trend, so still we can continue. Okay, many of my colleagues asked me how I started. Like everybody goes and prepares for a NEET. I also prepared several times, and all the times I failed, and none of the NEET and that's how I met in one of the GERICONs, my teacher who brought me here to the limelight. And please try to, whenever GERICONs are coming ahead and ahead, every year there is a GERICON conducted. GERICON is an annual CME conference that is happening from the House of Geriatrics. Please try to attend that. It is a 2 or 3 days program. You will learn lot of knowledge from the program, and that's how I started with the Geriatric House Call project. And to substantiate it like academically, so there is a paradigm shift in the management of ICU in the West also. Open model, I heard that few of the doctors here from the West also have completed the practice here. There is a paradigm shift in the management of ICU even in the West. It is now the trend of open model ICUs are coming. More attenders are allowed, and as you all know, the most dangerous instrument in a hospital is the doctor's stethoscope, and all those can be prevented by a home care. And a shift in the discharge criteria. What is discharge for an elderly? All the elders cannot be made to walk on discharge. So discharge criteria is somewhere manageable at home should be the discharge criteria, even in a hospital or in a home care. So you cannot be keeping the patient with you for a very long time. You need to change in the discharge criteria. So generally discharge criteria, the wound heals well and the patient is able to walk, patient is able to take orals, he passes stools. So that is a mild change in the discharge criteria. And generally, who will be your feeders? Once you start doing well, you will have a lot of feeders. You will have your oncologist, you will have your orthopedician, you will have your ICU physician, you will have your doctor colleagues who will be living elsewhere in the country or elsewhere in the part of the world. So they will be referring you, please take care of my grandmother, he needs a home visit. So there is an innumerable, there is a chance for doing a lot of home visits, and definitely you will not be out of the game. And in elders, you have all components. You will have an outpatient practice, you will have an inpatient practice, you will have a home care practice also. You can modulate how do you want and what the patient requires actually. So house call introduction, where the patient, whenever you go to a patient to go and visit them, there is a lot of patient related benefits. First, whenever they come to the hospital, they become restless. எப்போ நம்ம டோக்கன் வரும், எப்போ நம்ம நம்பர் வரும், எப்போ நம்ம போகலாம், அதுக்குள்ள அவங்க டர்ன் வரும்போது தான் அவங்க பாத்ரூம் போயிடுவாங்க. அப்போ then you will be wait, அவங்க அட்டெண்டர் மட்டும் ஃபைல் எடுத்துட்டு உங்க ஓபிக்குள்ள வந்துருவாங்க. Then you will be seeing with the file and the attender, and all this difficulties can be crossed over, can be simply hurdled by doing a house call. And what's the benefit for a physician? It is a single-handed relaxed diagnosis. You can do whatever you know. When you don't know, as I said you in the beginning, please take the help of your like-minded colleagues how to handle the patient. And even if you don't know nothing to do, please refer the patient to a nearby hospital and keep following and tracking, because learning has to happen side by side. So how do I substantiate that you will be having a peak geriatric practice? By saying that all over the world it is going for a graying nation. Because the birth rate has come down, the death rate has come down, there will be a stagnancy of the population. So the world should be prepared to handle elderly in all the arena, be it the like dresses, whatever they need. So the entire world will be geared up to know what the elderly requires. So what do you need to do in a house call? Some basic consent. If you have in a printed manner, well and good, or at least I allow this team to take care of this patient, because every happening should be medico-legally okay. Then what you need to do, you need to evaluate the patient, you need to do the vitals. Here it is you are doing as a single-handed person, you will have some assistant also. So kindly check for the 1-minute pulse rate, check for the sugars, check for the saturations, look for the lung bases. So sometimes it is sorry to say, certain physicians, they auscultate for sometimes namesake. Here it is not, you cannot do a namesake because you will not have a second opportunity. It is a single contact, so you should know the best out of the patient in that single contact itself. Kindly look for the bases, kindly look for the murmurs. Many of the patients will have aortic stenosis, many patients will have pulmonary artery hypertension. Look for the bases and always take a chance to look for the abdomen. Generally they will be clothed with lot of bed sheets, lot of woolen material, lot of dresses, sometimes with diaper. So it is a single chance of contact that you are going to establish with the patient. It is a golden chance, nothing you need to miss. Head to foot examination is a golden key. Sometimes what they would have called in for, they would have called in for acute confusion state. Tata mari mari pesranga, janal kitta yaro ninnitu irukanga, keela kulandingalam vilaadranga nu solranga. But avங்களோட problem வேற இருக்கலாம். It can be an acute retention of urine. So check for the bladder area, check for the umbilical area, check for any strangulated hernias. These are all very, very common. CNS examination, a basic examination should be done, whether he is able to sit or walk with himself, how is his walk, how is his gait, whether he is having any weakness, whether he is having some disequilibrium. please take time to see their lower limbs. Lower limbs gives a lot of clues, like you will end up seeing lot of edemas, cellulitis. Ant bites are very common in elderly, because suddenly கூப்பிடுவாங்க இந்த மாதிரி கால்ல ரத்தம் வந்திருக்கு, எலி கடிச்சிருக்கான்னு பார்த்தோம். But எலி கடிக்கிறதுக்கும் for a rat bite and an ant bite there is lot of difference. We'll have some clinical photographs in the end. And what are all the expected emergencies that you can encounter? You can encounter for some falls, fevers, unresponsiveness but breathing, unresponsiveness completely, different behavior, cancers, lower limb stories like kaal veenghi irukku, you will have lot of calls. So falls generally elderly very common, because there are three things that will be very helping for you to prevent a fall, that is your vision, your hearing, your joint response. All three will be in a low working manner in elderly. The commonest fracture encountered in elderly is the femur fracture, compression fractures in the vertebra, the wrist fractures, and these are the commonest fractures. Once you see a fracture, please triage the patient, whether the cause of the, what is the, generally following a fracture all will be interested in doing an orthopedic surgery. They will be interested in fixing a screw, they will be interested in fixing a plate. What is the cause of the fall? Whether it is some ECG related, cardiac rhythm related fall, whether it is a vertigo fall, whether it is a hypotension fall. So the fall needs to be evaluated, because once you get operated, the patient needs to walk back. If it is a non-treatable cause, operating on the patient will furthermore make him bedbound, and the family will have a lot of regrets on hospitalization and payments. So we will start earning a bad name. So once there is a fall, there is a fracture, please evaluate the cause of the fall. If they are fit, go ahead with surgery. This is not a program that you should not do surgeries. We are not too like empathy. If they are really fit, the fall has been because of some wet surface, whether some low vision or some slippery places mats are kept, then there is no recurrence. If all those can be prevented, there cannot be a second fall. Go ahead with the surgery. Lot of freedom will be there for the patient. If it is a Parkinsonism patient, if it is some complete heart block where they cannot be keeping a pacemaker for the patient, generally conservative manage like derotation wood will be helpful. So fever in elderly can be classified into two methods, like the old classification, above the umbilicus, below the umbilicus. Chest box and the bladder are the commonest causes of fever in elderly. The chest box can be contaminated by variety of ways, like simple as aspiration, or it can be a community acquired pneumonia, or it can be a nosocomial pneumonia, but lungs are commonly involved in elderly. And the bladder area is again commonly involved in elderly, be it in males, be it the prostate problems, or it can be because of the prolapsed uterus or incontinence of urine in the urine. So you can choose the antibiotics accordingly. So above the umbilicus, use gram-positive drugs which are efficient with gram-positive bacteria. Below the umbilicus, please use drugs which are efficient with gram-negative bacteria. Unresponsiveness with breathing can be as simple as hypoglycemia, can be hyponatremia, can be intracranial hemorrhage. So a lot of this needs to be evaluated. So a basic evaluation, what I said in the beginning, like recording the BP, pulse rate, saturation, CBG, you'll be able to do a basic evaluation. Like hypoglycemia can be treated, and even CVA, if it is an infarct, can be still treated at home. If it is an hemorrhage, depending upon the amount of, so medicine remains the same, the management remains the same. Triaging, whether they need to be treated, they need to be left alone, or they need to be referred. So this is the work what we will be doing there. So for issuing death certificates, there's a lot of confusions. So a doctor, what does law says correctly? The doctor should have seen the patient at least once. This is the current guideline. And what about elderly who are traveling from one son to the other? They would have been staying there in the Hyderabad for a very long time. They would have come to Chennai to meet one of their marriage. So suddenly they become ill. So in that conditions alone, the doctor should go in person to evaluate the death, see for any foul events, look for any strangulation marks. Please do not feel shy to undress the deceased person. Please undress the person. Many of the times you will see some foul play happening in the patient, but most of the times it can be a natural death. So what happens? So if it is really a worthwhile death certificate, you can give the death certificate from your own letter pad. You need not நீங்க எங்க கடைசியா பாத்தீங்களோ அவங்க கிட்ட போய் வாங்கிக்கங்க அப்படின்னு நம்ம அலக்கழிக்க தேவையில்ல. If it is a valid death, what does law says? The nearest physician, the physician who is available, the physician who comes and sees can give the death certificate. It is still valid. If you have some doubt about the cause of death, you can just declare death. For further, if you have any doubts, you plan for an autopsy, refer to the nearby GH for autopsy. You can write. There nobody will catch hold of you. Why did you only give the death certificate? Now you will be put behind bars. So lot of confusion, and many physicians are avoiding giving death certificates. By giving a death certificate, if it is really a valid death certificate, you will have an numerous practice coming after that. Lot of goodwill will improve in your society. So it is really a good deed, but you need to have a lot of patience. You need to see whether there is some foul play, and you need to see for the cause of death. Kindly go through the previous records also. If possible, take a photocopy. Unresponsiveness with breathing, probably commonest will be the hypoglycemia, hyponatremia, a cerebrovascular event, and many of the times there will be mismatch between the drugs and the patient's current trend. They would have been seeing the neurologist or the psychiatrist for the past 15 years back. 15 years continuously they will be using the same drugs. Over the 15 years the patient would have slowly come down, both physically, mentally. In every cause he would have come down. He would have not required such drugs. So அவங்க சொல்வாங்க, அட்டெண்டர் சொல்வாங்க, இந்த மாதிரி ரெஸ்பிரேட்டர் போடலன்னா அவ்வளவுதான், அவர் அடக்க முடியாது அந்த தாத்தாவை, அப்பெல்லாம் எகிரி குதிச்சுட்டு போயிடுவாரு, ரெஸ்பிரேட்டர் போட்டாதான் சரியா படும் அப்படின்னு சொல்லுவாங்க. But a point has come where he has used risperidone for more than 5 years. இப்போ பல்லப்பிடுங்க பாம்பு மாதிரி ஆயிட்டாரு, தண்ணி கூட அவரால குடிக்க முடியல. There is no point in giving risperidone to an elderly who even fails to drink water. So that is the intervention for home visit, where you need to cut down risperidone without any fear. நம்ம psychiatrist என்ன சொல்வாங்க, neurologist என்ன சொல்வாங்க, the physician who sees the patient there, whether he is MBBS or MD or whether he is DM, he is the judge. அவரால ஏஞ்சு கூட நிக்க முடியல, சாய போறாரு, அவரால தண்ணி குடிச்சா கூட இரும்ப போறாரு, அவருக்கு ரெஸ்பிரேட்டர் போட்டு, there is absolutely no use. So please be little judicial, sometimes polite, sometimes strong also. So cancers are really playing a huge pathway for home care. Lot of cancers are there, like starting from the lung cancers, ovarian cancers. Within a short span of time of 4 to 6 months, lot of catastrophic changes will happen. And cancer is one place where home care physician has a lot of role to do. And majority of the time, please do not overdo the job at cancers like tapping the ascetic fluid at home. Yes, you can tap. There is nothing wrong. But cancer patients are not going to come back from the cancer, especially the stage 4 cancers. All what you need to give a supportive management, some chance for painless death. So lower limb stories. Lower limb, commonest causes of lower limb edema in elderly. You will be seeing lot of elderlies with lower limb swelling. It can be because of anemia, it can be because of hyperproteinemia, it can be because of chronic kidney disease, it can be because of congestive cardiac failure, it can be because of hypothyroidism. These are the commonest cause of lower limb edema in elderly. The last common cause is the edema which is gradient, because they used to sit for a very long time. As sir used to say, they'll start serial by 5 o'clock and end by 10:30, 11, the last serial. By the time they will have a very large lower limb. So this is about a small study which we did. I will discuss during the lunch time. And generally elderly do not have a very strong backup of family support. So you need to moderate your fees according to their socio-economic status. This alone will make your home care practice viable. If you say start only if you give me 2,000, we'll make a visit, else the visit will be cancelled. You will be making only very few visits, and then you will start losing interest in doing the visits. Patients will be of various socio-economic status. Start doing visits for everybody, and overall income will be good. This is my experience, and it's up to you to how you take it about. So this we have already discussed. Clinical pictures I have separately. So why I had said about this staff nurse really plays a huge important role. So a lot of vertigo, like seeing the causes for vertigo, teaching them anti-vertigo exercise, doing some Eppler's maneuver, all can be done by staff nurses. Again, vertigo also. So this is one area where bed sores will be very predominant in elderly. So you should know your basic vagus grading of bed sores, whether it is simply a blister or it is only engulfed the subcutaneous phase, that is stage 2. Stage 3 is ischemic, stage 4 is infective. On the first 2 you can treat it. Bed sores, there are a lot of options available. சில பேர் எண்ணெய் போட சொல்வாங்க, சில பேர் நெய் போட சொல்வாங்க, சில பேர் தேன் ஊத்த சொல்வாங்க, வாழையில வைக்க சொல்வாங்க, மியூப்ரோசன் போட சொல்வாங்க, சில்வர் ஆயின்மெண்ட்ஸ் போட சொல்வாங்க, காப்பர் ஆயின்மெண்ட்ஸ் போட சொல்வாங்க, கோல்ட் ஆயின்மெண்ட்ஸ் போட சொல்வாங்க. Nothing works. Position change alone works. And grade 3, grade 4 bed sore needs to be debrided before treatment. Undebrided bed sore will never heal and it will start going inside and it will cause sacrum bone osteomyelitis. So 1 and 2, just position change, applying coconut oil or liquid paraffin, the work is done. 3 and 4, you need to debride. Parkinsonism patient, really this is a very much undealt area. Many of the elders will think that just nodding their head, pin rolling movements is a part and parcel of old age, and it is a commonest cause of unpredicted fall, because they will have a difficulty in walking and they will be just slipping across the mats and they will be ending up in a fall. So Parkinsonism patient, we need to have some awareness on Parkinsonism. Some basic drugs like levodopa, carbidopa, even if you know simply that the patient is having some pin rolling movements, some head nodding, some cogwheel rigidity, some globular tape positive, he is having difficulty, he is having the typical cogwheel rigidity, and he is having a tendency to fold his flex his phalanx and enroll his hands. So start small doses of half BD or 1 BD. Some benefit the patient will receive, or sometimes the reverse can happen. Patient will be an established Parkinsonism patient. He will be receiving all the drugs of Parkinsonism like rasagelin, ropinirole, levodopa, carbidopa, all the drugs, triexpendidyl. But a point will come where he has become very sick, not able to consume even water, but all the drugs will be going fully and he will end up in aspiration pneumonitis. At that point of time, you need to stop the levodopa, carbidopa, because levodopa, carbidopa, that is famously called as syndopa, is the commonest cause of visual, tactile, auditory hallucination in elderly. They will feel as if the ceiling is coming down, the fans are swinging here and there. The commonest cause, when it is not hyponatremia, when it is not hypoglycemia, the next common cause could be a drug-induced cause of hallucination, commonly because of levodopa and carbidopa. And of course, you will be encountering many of Ryle's tube patient, and some basic tips about Ryle's tube and catheter. Like catheter, you will have the latex and you will have the silicone. Latex needs to be changed once in 21 days. Silicone needs to be changed once in 90 days. Ryle's tube doesn't require any change unless it is blocked. It needs, because Ryle's tube changing is really a tough procedure both for the patient and the staff, and sometimes you might end in aspiration pneumonitis. So some basic tips on how to change a catheter, how to change a Ryle's tube, all this we cannot be able to do, but you should be in a position to find the correct mistakes, and when the staff are not able to do, sometimes you should be also able to do a Ryle's tube or catheter. If you have lost touch in that, you can appoint a ICU nurse as one of the nurses in your team. I am simply going through with simple home visits to complicated home visits, because we do from A to Z. So that, see, you might be thinking this all we are doing in inpatient care. Everything is done in the background of the home environment. So COPD patients, yes, you should be also little bit trained on this continuous positive pressure machines, what we call as BiPAP and CPAP. You should know some basic technology, what is inspiratory rate, what is expiration, and how much to keep in the inspiratory phase, how much to keep in the expiratory phase. All depends upon your interest. So once if you are interested, we can have a second meeting like this. So who are going to go for more intensive management, we can have on that. So chronic kidney disease patients also you will be encountering, and there will be several alone living elderlies. Lot of people you will be seeing as couples. They will be happy, they will be managing. All what you need is to sit for 10 or 15 minutes without attending any phone. Talk with them, tell about yourself. They are also interested in knowing about your family, your parents, your wife, your children. நம்ம டாக்டர் என்ன செய்யறாருன்னு அவங்களுக்கு ரொம்ப ரொம்ப பிடிக்கும் கேட்கறதுக்கு. அவங்களும் கொஞ்சம் சொல்லுவாங்க, அதையும் கொஞ்சம் கேட்டுக்கிட்டு அவங்க எல்லாமே ஜென்ரலா இந்த மாதிரி happy living elderly will be well settled. Whatever the fees you request for 2000 or 1500 or 1000, they will be simply giving the fees. All you need to do is sit, talk, make them comfortable, and they also need doctor அடுத்து எப்போ வரணும் நீங்களே எழுதிருங்கன்னு அப்படின்னு சொல்லுவாங்க. Whatever is your convenience, 1 month or 2 months or 3 months, you can write. And also you will be seeing some elderly like this. Don't get afraid of them. They are generally very active. They do not fall because their center of gravity goes very very down. Their skin and bones சும்மா அப்படியே புடிச்சே கதவெல்லாம் ரவுண்ட் அடிச்சிட்டு வந்துருவாங்க, கீரெல்லாம் வெட்டுவாங்க, உட்கார்ந்து ஏஞ்சிப்பாங்க, தேய்ச்சிட்டே பாத்ரூம் போயிட்டு வந்துருவாங்க. They are also very healthy only, and they generally also like to get photographs done. So they never have any chance to smile. So please ask them, கொஞ்சம் நான் உங்க போட்டோ எடுக்கலாமா, சிரிக்கிறீங்களா? So it is a mixture of both science, moral science, social science, history, geography. You need to sometimes, if you are good in singing, please sing some songs for them from A.M. Raja or some good movies, or how we are going to handle. So this is one thing. When you manage some intensively sick patients, coughing on feeding test has to be done. Whenever you are going to take a sick patient at home, what are all the basic facilities you need to manage a sick patient? You need to have a semi-fowler's cot, you need to have some air mattress, you need to have some intravenous access. The cough on feeding test tells you whether the patient requires a rice tube or the patient can be fed directly. So whenever you give a bout of water, when they go for a cough, it means they are candidates for aspiration pneumonitis. Never hesitate to put a rice tube for them. And what will be the red flag signs? You are managing the patients elderly, they are very sick, you know they are sick, you are starting IV fluids. What are all the red flag signs? Decreased urine output. Urine output will be failing, it will be becoming dark, it will be the swelling of lower limbs will happen, and they will having some rattling sound. Gar 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 gar, the fluid will not be going out, it will be just settling in the lungs. In such situations, every visit, please counsel the attender, it is a sinking ship. So make them mentally prepared, because breaking the death news is really an art, needs to be done with some empathy. Just most of us are having valid experience in our age, so we'll be breaking it very politely, but preparing them for death is very very essential, which will avoid unnecessary odd situations. இல்லாட்டி சொல்லுவாங்க நல்லா தானே இருந்தாங்க, சாயந்தரம் கூட நீங்க வந்து பார்த்துட்டு போனீங்களே, நீங்க கூட நல்லா இருக்காருன்னு சொன்னீங்களே அப்படின்னா. When you see the red flag signs like decreased urine output, swelling of the entire body, நீங்க வென்ஃப்ளான் போட்ட இடம்லாம் swelling ஆயிட்டு இருக்கு, the cubital fossa and all is swelling, the heel is swelling, the foot is swelling, then the patient is sinking. So keep preparing the patient's attender. So this is the minimum supporting basic care model. This I have already mentioned. So this is how we do. So we have a rice tube. You can take as sick as this patient. And regarding to restless elderly, the restless elderly will be generally because of acute urinary retention. The தாத்தா நிக்க மாட்டார் ஒரு இடத்துல, எல்லாத்தையும் கடிச்சு பிடிச்சு துப்பிடுறாரு, எல்லாரையும் அடிக்க போறாரு அப்படின்னு பாத்தீங்கன்னா, generally it can be acute retention of urine. Elderly are very very worried about passing stools. Sometimes they are constipated for weeks together, days together. They sometimes manhandle the stools, விரல விட்டு எடுப்பாங்க. It can end in bleeding. So they are very particular about the stools, and it can be an obstructed gallbladder stone, especially the fat 40 female who were there in the 40s would have slowly creeped to the 80s, and they are bedbound for a very long time. The stone goes and plugs to the gallbladder, and you will be ending up with acute cholecystitis. So this is an acute retention of urine. The abdomen can be as full as this, and it will be a dark high colored urine, which I think it should have been there for at least more than 1 or 2 days. It would have been accumulated. So just for interest, I have kept few Parkinsonism patient faces. All Parkinsonism patients will not have the typical mask-like face of leaning forward, walking with the scissoring gait, the Fessenden gait. It will be as you know, Parkinsonism is a syndrome. It can vary from simple mild tremors like pin rolling movements, head nodding, difficulty in walking, drooling of saliva, everything can be there. This is a sunset sign, like திடீர்னு பாட்டியோட பார்வைலாம் மாறிடுச்சு. This also it's called sunset sign, what you see in elderly Parkinsonism patients. So old stroke patients is again one entity where the patients after some 2 or முதல்ல stroke வந்தோனே அந்த ஃபேமிலி ரொம்ப என்ன பண்ணுவாங்க, இருக்கிறதுல பிகெஸ்ட் ஹாஸ்பிட்டல்ல போய் ட்ரீட்மெண்ட்லாம் பண்ணுவாங்க. எல்லா ட்ரீட்மெண்ட்லாம் முடிஞ்ச பிறகு post stroke there will be patient will have some depression. ஒரு 2-3 மாசம் கழிச்சு எல்லாம் அட்டெண்டன்ஸ்லாம் வரதெல்லாம் குறைஞ்சிடுவாங்க. அப்புறம் இதுக்கு மேல நான் ஏன் மாத்திரை சாப்பிடணும், இதுக்கு மேல நான் இருந்தா என்ன போனா என்ன அப்படின்னு ஒரு டிப்ரெஷனுக்கு வந்துட்டு முக்கியமா like drugs like amiodarone or some rate rhythm controlling agents they will stop and they will be having a recurrent repeated stroke. So especially stroke patients, you have to see whether sometimes patients on clopidogrel aspirin whether they are taking or not taking, they end up in stroke. But patients who are leaving the rate rhythm controlling drugs like amiodarone or any drugs of that manner, so they will be ending up with a recurrent stroke. So you should, any stroke patients, please see for their old history. What was the cause of stroke? Whether it was an ischemic stroke or a hemorrhage stroke. If it is an ischemic stroke, what was the cause? Whether it was because of any arrhythmias. So you have to look for the old prescription, and generally in a house call take some time to know the history from back. இப்போ என்ன பிரச்சனை சொல்லுங்க அப்படின்னு கேட்டீங்கன்னா you will not be able to solve. You should take the first visit alone. You can invest lot of time or you can devote lot of time, whichever term you want to understand you can take. All the subsequent visits you can make within 5 minutes if you are able to remember the history. So we have come to the fag end. So this kind of simple diaper rashes also you will be seeing in elderly. Simply stop the diapers, put them on catheter for some time or put some underpads. It is very very easy. So this is grade 3, grade 4 bed sore. This is also grade 3, grade 4. This is after debriding. You will see some good granulation tissue. And apart from elderly, you can see some other persons also who need home care, like muscular dystrophy patients. This is one of a girl with muscular dystrophy with pressure sores, a 10 or 12-year-old girl. She is no more now because she ended up with respiratory arrest. So these people also can be helped in home care, not alone the elders. Elders will be our top priority, but these children also can be helped. And come to the end of today's session. I would like to acknowledge Professor V.S. Natarajan Sir's Geriatric Foundation for helping me to give this chance for me to talk in front of you what I have learned for these few days. And I also like to acknowledge because doctor used to ask me how did you document all those things. He is my first year class teacher, Professor T.L. Adlumani sir, who made a point me to write whatever you are doing. Whatever you are doing, please write, and whatever you are writing, please do. And accounting is very very important. And this is the first time in 2012 I met V.S. Natarajan sir, and this is Professor T.S. Kanaga madam, who has also helped our center in developing our home care model. And center staff, you need to have a fantastic nursing team. I am repeatedly saying this point because nursing makes a difference. Simply carrying a bag and making diagnosis and coming back will not help in a long run. Please develop a team. Team matters. And all these sisters needs to be compassionate, so please take some time to educate them. If you are getting a learned nurse, they will be working in an attitude what they have learned already. But for geriatrics, you need compassion and empathy right in every other corner. They love to be pampered, elderly love to be pampered, so please do not forget that. And this is our center. And last but not the least, if you are a home care physician, you should have a fantastic family support, because you will be going odd times, coming in odd times. Sometimes you will be receiving calls here and there. Hypoglycemia ஆயிடுச்சு சார், என்ன பண்ணணும் அப்படின்னு உங்ககிட்ட உங்க ஆர்டர்ஸ் ரிசீவ் பண்றதுக்காக இருப்பாங்க. So also care about your family also. Take them here and there outing also, because they will be simply missing you. So please take care of your family. And thank you for giving me this opportunity. This is the place where I am coming from, Old Pallavaram, and this place is called Pallikaranai. It's a marshland, and you will see lot of birds also. If you find time, those who are interested in doing house call, if you are interested in doing a house call, you can visit our place. You can visit our place. You can visit our place, and we will go through our center, lot of how it is happening. If you want to have a one-day visit to our center, you can come see how the model works. You can travel with us for a day, and it will be helpful for both of us. So you will be learning also, and we will be also telling you what we are doing. It will be a revision for us. And thanks for the opportunity once again. If you are interested, during your lunchtime, I have some clinical photographs. I can simply scroll through. Thank you and have a nice day.
Thank you, Dr. Harishankar. That was masterclass in geriatric house call. I'm quite confident that everybody benefited and came to know about one or two new things. So we'll be having more of these sessions and we'll keep you updated. Dr. Harishankar our president the problems of the elderly. The first and geriatric house call manual from founder and chairman Dr. V.S. Narayan. Dr. Jaishankar. Dr. Jaishankar does a lot of house calls on our behalf. I request Dr. Anwin Jose to come over and collect the certificate. Mr. Elias. Dr. Kumaran Amaresan. Dr. Kumaran is known to Dr. V.S. since his childhood. He is son of famous nephrologist Dr. Amaresan. I request Dr. Karthikeyan to come and correct the certificate, sir. Dr. Karthikeyan is a UK returnee. He practices at Tiruvanmiyur area. He runs the Rebelli hospitals. Dr. Bhavani. Dr. Bhavani does a lot of house calls in Srinagar area. She is a senior physician. Dr. Uma Karthikeyan. I request Dr. Ganesan to come and collect the award. He is a diabetologist. He also conducts a lot of house calls. Thank you for coming, Doctor. Dr. Arul Modi. Thanks for coming, Doctor. Mr. Binny Yogaraj. Mr. Binny is a young and energetic physiotherapist who runs 2 centers in the city. I request Dr. Radha Ganesan to please come and collect the certificate. Dr. Radha has done quite a long stint in the Gulf in geriatric care. She was academic coordinator at Vijaya Hospitals. Dr. Somasundaram. Dr. Somasundaram is one of our senior most doctors on the panel. Dr. Santosh Manigandan. He is a postgraduate in geriatric medicine, PG student. Dr. Santosh should know that Dr. V.S. Natarajan started the first geriatric unit in India, and he was the first professor of geriatric medicine, and he was instrumental in starting MD geriatrics in India. That's all, Doctor. We can have Dr.